Hello, today we will discuss fetal-placental insufficiency and torch infections. So what is fetal-placental insufficiency? It's also known as placental dysfunction or uteroplacental insufficiency. It is a complication of pregnancy in which the maternal placenta either does not grow adequately or is damaged due to several reasons. This placental insufficiency causes inadequate supply of nutrients to the baby. It also fails to remove the waste product from baby's blood. This harms the baby and can cause premature birth, low birth weight, or birth defects. Let's take a look to the placental physiology. This is so-called physiological changes result in the dilatation of the maternal arteries throughout the inner one-third of the myometrium. The result of this is a conversion of the uteroplacental blood supply into a low resistance, high flow vascular band, which is necessary for fetal growth and development. Failure of this trophoblast invasion is associated with a number of later pregnancy complications, including pregnancy-induced hypertension and intrauterine growth restriction. Placenta transfer of nutrients, waste products, hormones, gases increases with advancing gestation as the structures between the maternal and fetal circulation become thinner. There is no direct connection between the two circulations, and this is placental barrier in later pregnancy is the site of microvilli of sinusotrophoblasts, which increase the available surface area for nutrient transfer. Further, sinusotrophoblasts and fetal mesoderm are reduced in thickness and villus vessels delayed. The fully formed placenta is a red, discoid structure approximately 2 to 3 centimeters in thickness, and the insertion of the umbilical cord, the average weight at term is about 500 grams. Umbilical cord, so you can see the picture placenta, and the umbilical cord contains the two umbilical arteries and the single umbilical vein normally attached to the center of the placenta. Usually they immediately divide to provide a very rich blood supply on the fetal side, which completed with the maternal blood in the intervillous spaces. The two arteries and the single vein of the umbilical circulation lie in supporting myomatous tissue, divided from the mesoderm and termed Wharton jelly. This jelly acts a buffer, attenuating any pressure on the vessels and preventing knicking on the cord. So actually, placenta have different functions. One of these functions is barrier function. Barrier function, so placenta protects fetus from maternal toxics. Respiratory function, the anatomy of the fetal and maternal blood supply to the placenta ensures efficient transport of oxygen and carbon dioxide, certified by diffusion. The difference in oxygen dissociation and characteristic of the blood from maternal blood further enhances the fetal oxygen uptake. Excretory function. Little is known of excretory function of the human placenta, but it is known that placental transfer of molecules like urea is linked to lipid solubility. Nutritional function of placenta. Since the permeability of the placenta to glucose is much greater than would be expected from its liquid solubility, it's now known that there is a specific transport mechanism for glucose. This is known to be an integral membrane protein. An endocrine function of placenta is a large number of hormones are produced by placenta. This includes hormones analogs to adult hypothalamic and pituitary hormones and steroid hormones. A variety of other products are produced by placenta. Maybe many of these are glycoproteins such as pregnancy-associated protein A to D, pregnancy-specific glycoprotein, and placental protein 5. The functions of these are being clarified but remain uncertain in human pregnancy. Placental insufficiency classified by time of manifestation. The primary placental insufficiency develops during the formation of the placenta before 60 weeks of gestation. Secondary appears when the placenta formation process is over. It's caused by some extra influences. First of all, these are diseases which pregnant woman was suffering during pregnancy. The primary fetoplacental insufficiency, usually women with in the risk group with primary incompetent pregnancy, women who has infertility in anamnesis, pregnant women with operation on the uterine, when pregnancy is completing with acute persist torch infections, during pregnancy with operation on the uterus, when pregnancy is inductional. So these women are in the high risk of the primary fetoplacental insufficiency. In the secondary placental insufficiency, it's usually caused by some extra influences. First of all, these are diseases which pregnant woman was suffering during pregnancy. And regarding its process, the primary and secondary fetoplacental insufficiency are divided to acute, chronic, compensative and subcompensative and decompensative forms. In pathogenesis to the acute fetoplacental insufficiency, acute disorder of the placental perfusion plays a great role. It leads towards a significant circulatory disorder in placenta. It often rises under the following conditions. It may be premature separation of the normal placental position, the placental presentation, the prolapse of umbilical cord knots, the prolapse of small parts of the fetus. In pathogenesis of the chronic fetoplacental insufficiency, the main meaning is taking gradually decidual perfusion, which occurs as a result of lowering of the compensatory adaptive reactions as the reply for the actions of the pathological condition of the mother's organism. Compensative fetoplacental insufficiency develops when there are threat of interruptions of pregnancy, non-typical forms of the late gestation, for example, edema of pregnancy, light preeclampsia. Subcompensative fetoplacental insufficiency develops during pregnancy with extragenital pathology, and decompensative fetoplacental insufficiency develops in time of hypertensive forms of the late gestation. During physical gestation, placental vessels are found in the condition of deliscence and do not react on contraceptive stimulus. This circumstance provides equal entering of oxygen and neutral substances to the fetus. Refractoriness of the placental vessels and mother's system of blood circulation are provided with products of the endothelial factors of relaxation, prostacyclin and nitrous oxide, and the activity of this prostanoid is the basic condition of the adaptation of the mother's vessel towarding increasing load on the blood circulation, and it also provides systematic vasodilatations and lowering of AD under the progressive pregnancy. Primary and secondary acute chronic relative, absolute compensative, subcompensative, and decompensative fetal placental insufficiency. Forms of fetal placental insufficiency is hemodynamic, membranous, and cellular forms. Hemodynamic provoked by disorder of uterine, placental blood flow. Membranous placental membranes are unable to transport metabolites. Cellular form linked with decreased metabolic activity of placental cells. And pathogenesis of placental insufficiency, insufficient invasion of trophoblasts into the spiral arteries of the uterus, in consequence with the less amount of mother's vessels involved in the placental blood circulation, the disorders of the products of the factors which provide the distance of the placental vessels. These are prostacyclin and nitrous oxide, lowering prostacyclin and nitrous oxide base synthesis in the uterine and fetal placental blood circulation is accompanied by vessel spasm in this area and separation of the mother's blood circulation from the fetal one. Main causes of fetal placental insufficiency. It can be infections, specific and non-specific infections, diabetes, chronic high blood pressure, blood clotting disorders, anemia, certain medication, smoking, and drug abuse. When it comes to diagnosis of fetal placental insufficiency, first of all, we need to learn anamnesis of mother. We need to check clinical laboratory investigations. And when we have fetal placental insufficiency, all placentals must be checked for morphological and immunomorphological investigations. And of course, ultrasound examinations must be done in the first, second, and third trimester. And Doppler telemetry must be done, and I will talk step by step about these diagnostic forms. And investigation of estradiol, placental lactation, and progesterone in blood. So clinical laboratory investigations. For laboratory examinations, first of all, we have to check PCR for sexual transmitted infections. Also, bacterioscopy and bacteriological examination must be done. And diagnostic of antiphospholipid syndrome, so coagulation test, antiphospholipid and anticardiolipin antibodies must be checked. And diagnostics of placental hormones, estriol, placental lactogen, and also placental alkaline pH, placental alkaline phosphatase in serum must be checked. And Diagnosis of gestational diabetes, polynephritis, anemia, other extragenital condition of mother must be checked. And of course, ultrasound examination in the first, second, and third trimester. What is necessary to value during the ultrasound examination? It's an intrauterine fetal condition. Also, we must measure the length of the cervix and diameter of the intropharynx of the cervix. We must check placental location and the thickness and structure of placenta. We must check presence of the uterine walls tension and signs of the less or much amniotic fluid. So amniotic fluid index must be checked first of all, and the character of motor and respiratory activity must be checked. And also we do bioprofile of fetus, so we do non-stress tests. We have check for respiratory movement of the fetus, motor activity of the fetus, fetal tone, size of amnion fluid must be checked, and appraisement of the fetal bioprofile. If we have 7 to 10 scores, it's satisfactory fetal condition. 5 to 6 scores, doublet test, and 4 scores and lower, it's pathological appraisement of the fetal bioprofile. And dopplerimetry must be done. Here we estimate blood flow in the uterine and umbilical arteries, measure index of resistance in vessels, and we have checked blood flow in placenta. Also, blood flow in fetus can be estimated by Doppler of medullary artery. So classification of the blood flow in dopplerimetry. 1A, it's abnormal blood flow in both uterine arteries. 1B, abnormal blood flow in umbilical artery. Second, abnormal blood flow in uterine artery and umbilical artery. And third stage, reverse diastolic blood flow in umbilical artery. In diagnostic of placental insufficiency, so we do laboratory examination and ultrasound examination. If we see in laboratory examination decreased level of placental hormones and also placental alkaline phosphatase in serum. And we see in ultrasound examination structural changes of placenta. It may be classification, placenta megaly, thin placenta, or premature placenta aging. And if we see changes of blood flow on Doppler, so we can put to this patient diagnosis of placental insufficiency. We can think here about placental insufficiency. What causes placental insufficiency? Placental insufficiency causes fetal hypoxia, and fetal hypoxia brings to fetal growth retardations. What is fetal hypoxia? It is one of the main complications of pregnancy with a frequency of 4 to 6%. It is most common reason of antenatal and intranatal death of fetus. So hypoxia means insufficient oxygen supply and or utilization by tissues. The causes can be maternal, fetal, and placental. Maternal causes of fetal hypoxia may be extragenital pathologies of mother, infections like torch infections. It can be bleeding, intoxications, and other reasons. Fetal reasons can be intrauterine infections, brain misdevelopment, encephalopathies, and placental reasons. It can be secondary placental insufficiency or primary placental insufficiency. These all reasons can bring to fetal hypoxia. We have 4 types of hypoxia in hypoxic classification. Hypoxics, it's a low concentration of oxygen in the blood. Circulatory type, it's disorder of transporting of the oxygen when its blood concentration is normal. Hemic type, its level of hemoglobin is decreased. And tissue type, low utilization of oxygen by tissues. Severity of hypoxia, functional, metabolic, and destructive function. It's mild for actually only hemodynamic changes happen here. So we can see tachycardia of the fetus, increased blood pressure. In metabolic form, we it's moderate form. We see here irreversible tissue changes, and destructive form, it's severe form, irreversible tissue changes. And to diagnose hypoxia, we do cardiotocography, ultrasound examination, of course, biophysical profile of fetus, ultrasound placentocography, hormonal examination, and chordo and placentastasis if it's needed. Some features of cardiotocography show us the hypoxia of the fetus. So in abnormal cardiotocography, we will have heartbeats. If we have less than 100, it shows us bradycardia of fetus. More than 180, it shows tachycardia of fetus. Also sinusoidal pattern for more than 10 minutes. Also variability of heartbeat rhythm is less than 5 or more than 90 minutes. It's also abnormal. And deceleration, if we have a typical late, single, or prolonged for more than 3 minutes deceleration, these all features of cardiotocography show us that the fetus has a hypoxia. If we have hypoxia, corrections will be its improvement of blood perfusion, normalization of metabolism, improvement of oxygen interchange, blood vessel dilatation, and uterine muscle relaxation. And another part of our lecture will be about TORCH syndrome. TORCH syndrome, it's a complex, is a medical acronym for a set of prenatal infections that can lead to severe fetal anomalies, even death. They are a group of viral, bacterial, and protozoan infections that gain access to the fetal bloodstream transplacentally via the Hornick villi. So what means TORCH syndrome? T, it stands for toxoplasmosis. O, for other infections like syphilis or varicella zoster or parvovirus. R for rubella. C for cytomegalovirus, and H for herpes simplex viruses too. TORCH syndrome, it's a group of viral bacterial and protozoan infections that gain access to the fetal bloodstream transplacentally via the Hornick villi, or hematogenous transmission may occur at any time during gestation or occasionally at the time of delivery via maternal to fetal transfusion. All torch infections can lead to fetal loss, to fetal death, intrauterine growth retardations, hearing loss in the newborns, anemia, fever. It can bring to eye defects, hair diseases, thrombocytopenic purpura, and hepatosplenomegaly. Toxoplasmosis is a disease caused by intracellular parasite Toxoplasma gondii. Infections of human occurs by acid contaminated soil, salad, vegetables, ingestion of raw or undercooked meat containing tissue cysts. It may be sheep, pigs, rabbits, and etc. Outbreaks of toxoplasmosis have also been linked to the consumption of unfiltered water. Organisms and transmissions. Toxoplasma gondii has 3 different forms. The definitive host is cat. The oocytes produce the spores in the enteroepithelial cells of cat and pass into feces. Spores become infected after 21 days of shedding. Exhaustion in the human gut after ingestion of the infected sporozoites. Sporozoites circulate in maternal bloodstream. Trophozoites develop and multiply within the cells, cause cell rupture and death. Host immune response activated and begins third stage. Host antibody formation reaction converts the parasites from the trophozoites into tissue cysts, form and no longer circulate in blood to cause infection. Fetal infection occurs only in acute phase of infection when Toxoplasma gondii in maternal blood transported to placenta and fetus. It typically occurs 5-7 days after maternal inoculation. After the virus invades the placenta barrier, it spreads throughout the fetus via their vascular system. So, signs and symptoms. Infected pregnant women usually no clinical manifestation. Also, some may have a mild mononucleosis like syndrome, regional lymphadenopathy, or occasionally chorioenteritis. Similarly, infected neonates are usually asymptomatic at birth. About 10% of women have signs and symptoms during acute infections. It can be a lymphadenopathy and other symptoms like flu. It may be fever, headache, muscle pain, sore throat. And there are some rare symptoms that severe symptoms. It's polymyelitis, dermatomyositis, and chorioetinitis. These are rare symptoms of toxoplasmosis in mother. And fetal clinical manifestation, if acute toxoplasmosis is occurred during pregnancy, the infant is at the risk of developing congenital toxoplasmosis. Clinical triad of signs associated with congenital toxoplasma infection is chorioentinitis, hydrocephalus, and intracranial calcification. These are the 3 congenital toxoplasma infection signs. And there are also maybe other symptoms like fever, a rash, microcephaly, seizures, jaundice, and thrombocytopenia or lymphadenopathy. For diagnostic evaluation, immunoglobulin G, serial immunoglobulin G measurement for maternal infection, amniotic fluid PCR for fetal infection, serologic testing, brain imaging, cerebrospinal fluid analysis, and ophthalmologic evaluation for neonatal infection, and PCR testing of various body fluids or tissues. When it comes to treatment in pregnant women with an established recent infection, the medicine is treated is pyrimidine, 3 grams daily in divided doses should be given. In neonates, it's pyrimetamine, 50 milligrams twice daily for 2 days, and then 50 milligrams daily. And also sulfonidazine, 75 milligram per kilogram daily in 2 divided doses for 2 days, and then 50 milligram per kilogram twice daily. And also folic acid is added for treatment. It's 10 to 20 milligram daily to newborns. Another infection may cause a lot of abnormalities in newborns. In fetuses, it's a rubella. Rubella infection caused by rubella virus. Intrauterine infection with rubella virus is referred to as congenital rubella infection or syndrome. Infection with rubella earlier in pregnancy cause worse prognosis and neonatal complications. The virus can be transmitted to the fetus through the placenta and is capable of causing serious congenital defects, abortions, and stillbirths. Infections in weeks 8 and 10 of pregnancy result in damage in up to 90% surviving infants. Multiple defects are common. Infections in 11-16 weeks of pregnancy as a risk of damage reduced to 10 to 20%. Over 18 weeks of gestation, fetal damage is rare. So you can see here, diseases caused by rubella viruses. It can be in newborn microcephaly, heart diseases. Newborn may have purpura in the skin. Also in the eye, it may be cataracts or iris dysplasia, and in the head, it can be microcephalia or hydrocephalia. Also, newborn may have developmental anomalies like general or learning disabilities, usually 55%, or insulin-dependent diabetes, or late onset disease at 3-12 months with rash, diarrhea, pneumonia, and high virality. And sensorineural deafness may also happen. For diagnostic evaluation, it's serological tests to detect rubella-specific antibodies. Routine rubella immunoglobulin G is done in the first trimester. Rubella immunoglobulin G is done in suspected case, and presence of antibodies plus rash confirms the diagnosis. And when it comes to treatment, it's supportive care and surveillance is the only recommended option available at this time. Close monitoring within the first 6 to 12 months of life is recommended, particularly for the evaluation of hearing impairment. Prevention is considered the most important aspect as far as the management of congenital rubella infections concerned, and preventive measures include recommended immunization, testing of pregnant women for rubella immunity, and proper counseling regarding avoiding exposure. And here fetal death higher with infection in first semester, infection rate is higher with infection in third semester, risk of fetal infections in the first semester, risk of 15%, second semester 25%, and in the third trimester 65% of risk of fetal infections. Cytomegalovirus virus. Cytomegalovirus is a double standard DNA herpes virus, the most common congenital viral infection. The cytomegalovirus seropositive rate increases with age, and geographic location, socioeconomic class, and work exposure are other factors that influence the risk of infections. Transmission may be close contact, young children attending daycare center, usually it can, from saliva, urine, blood, or breast milk. And route, it also can be possible routes of transmission like sexual contact, organ transplantation, transplacental transmission, transmission via breast milk, and blood transfusions. Clinical features at birth, most infants are asymptomatic. There may be a few development, it's a premature, hepatosplenomegaly, microcephaly, fetal and jaundice at birth, thrombocytopenia, and pneumonia newborns. And for diagnostic testing of urine saliva for cytomegalovirus by PCR and viral cultures, detection of cytomegalovirus immunoglobulin G antibodies in blood, and postnatal evaluation include physical and neurological examination, laboratory testing, a hearing assessment, optal assessment, and neuroimaging. For management of cytomegalovirus, we can choose one of three medicines. It can be cancercyclovir 5 milligram per kilogram for every 12 hours for 14 days, or it can be valganciclovir 900 milligram oral daily for 3-6 months, or cytomegalovirus specific hyperimmunoglobulin also may be chosen for treatment. So hepatitis B and C can also be included among the other viruses group. Hepatitis B acute form during pregnancy, usually not severe, not associated with increased mortality or tetragenicity, not an indication of termination of pregnancy, but may increase the risk of complication in infant. It can be low birth weight and prematurity. So early in pregnancy, transmission rate is 10% and 60% at the time of delivery or close to the time of delivery. When it's come to vertical transmission, the intrauterine infection of fetus is very rare. Mostly transmission happens during delivery or after delivery. After delivery, it can be during breastfeeding if mother has scratches on her nipples usually. Transmission to the baby in the absence of immune prophylaxis is hepatitis B surface antigen positive mother 10 to 20%, hepatitis B surface antigen plus hepatitis B antigen positive mothers 90%, and acute hepatitis B, transmission in the first semester 10%, during third semester it's probably 80%. delivery can be can be chosen. Any method of the delivery can be chosen. It's not necessary to choose a cesarean section method. When it's come to neonates, 75 to 80% of prenatal infection children will be carriers of the virus. Becomes evident 6 months after birth. Usually the course is sublingual and chronic. Greater risk of hepatic cirrhosis and hepatic cancer in these newborns. And fulminant disease more frequently occurs in newborns whose mothers are chronic carriers of hepatitis B virus. Hepatitis C in pregnancy, it's usually pregnancy usually under the risk. We have here cholestasis of pregnancy usually appears. Then endogenous fetoplacental interferon may have a favorable effect on the course of hepatitis C, as the presence of esophageal varices of capillopathy risks are higher. When we have hepatitis mothers, so we have to check SAT and ALAT once every trimester. In addition, we have to check always albumin, bilirubin, NAR, anti-HBs, hepatitis RNA, so once every trimester must be checked. And vertical transmission of hepatitis C is infrequent, 6% in hepatitis C virus RNA positive, and 15% if hepatitis C plus HIV positive mother. The risk of hepatitis C transmission is dependent on the level of mother's viremia. If hepatitis C RNA negative, risk for the baby is 0%. Hepatitis C and delivery. The method is delivery is not important in transmission. Caesarean selection is not indicated. So how in hepatitis C and hepatitis B, any method of delivery can be chosen. Induction of the delivery due to hepatitis C is not necessary, and prefer external methods of following the fetus. Also, there are no data of infection transmission. We are using the scalpel electrode. So breastfeeding is allowed, the same and hepatitis B and hepatitis C. Breastfeeding is allowed. No transmission via breast milk has been documented. So when it's come to neonates, not much experience yet. The virus was discovered in 1989. Hepatitis C is not tetragenic. Babies have been born healthy usually. When baby is infected, baby has chronic infections. No vaccine is needed then, no immunoglobulin is needed, and recommended to do lab tests of child once a year. Herpes simplex virus, you can see in the picture newborns who was born from mother who had herpes simplex virus. So they have herpes papulas in their body, in the face, in the eyes, and other parts of the body. Herpes simplex virus infection during pregnancy can pose a serious threat to the developing fetus and newborn infant. Transmission typically occurs via direct contact between the neonate and infected maternal genital tract. If the primary herpes simplex virus infection was acquired during pregnancy, then the risk of transmission is greater as compared with reactivation of previous infection. Incidence of neonatal herpes simplex virus infection ranges from 1 in 3,000 to 1 in 10,000 births. Herpes simplex virus is a member of herpes viridae family of viruses. Enters the host through the inoculation of oral, genital, or conjunctival mucosa. Inoculation can occur through breaks in the skin. Dissemination of the virus eventually allows the virus to reach the dorsal root ganglia, where it remains dormant for the rest of the host's life. Antiviral drugs do not affect latent herpes virus infections, and therefore infection is lifelong. Intrauterine herpes virus is a rare occurrence and most likely is caused by maternal viremia associated with primary infections during pregnancy. Intrauterine infection is associated with hydrops fetalis and in utero fetal demise. The characteristic triad noted at birth includes skin lesion consistent of vesicles, ulceration or scarring, eye damage, and sinus abnormalities such as hydrocephaly and microcephaly. Diagnosis of neonatals with herpes virus infection can be established through any of the following methods: isolation of virus in culture, detection of DNA via PCR assays, detection of herpes virus specific antigens using rapid direct immunofluorescence or enzyme immunoassays. For treatment, suppurative viral therapy from 36 weeks until delivery. It can be valacyclovir or acyclovir. Valacyclovir 500 milligram oral or 400 milligram orally acyclovir. Cesarean section is recommended for all women in labor with active genital lesion, prodromal symptoms such as vulvar pain. And varicella zoster herpes virus family. It's DNI virus. Maybe you hear a different name of varicella zoster like chickenpox virus. If infection occur in the first trimester, 4.9% risk of congenital varicella. Congenital syndrome, it's a lump, hypoplasia, ocular abnormalities, sinus abnormalities, and dermatomal scarring. For diagnosis is serology of varicella zoster, immunoglobulin G and M. For screening is routine screening, generally not recommended. For prevention, if a pregnant woman is exposed, perform ST80 varicella immunoglobulin G. Exposed neonate should receive varicella zoster immunoglobulin G prophylaxis. And other perinatal infection may be syphilis, transmission if happen between first and second trimester, may happen between first and second trimester of pregnancy. The symptoms will be skeletal abnormalities, pseudoparalysis, persistent rhinitis, musculopapular rash. And for diagnosis, it's specific immunoglobulin M fluorescence antibody. And for treatment, the medicine of choice will be benzathine and penicillin G. Also, another viruses during pregnancy may be malaria or vivax and falciparum. Transmission from infected blood, administration. Symptoms may give stillbirths or intrauterine growth retardation in newborn. Also, newborn hemolytic anemia or jaundice may give a newborn. Diagnosis: blood smear Medicine of choice is chloroquine or chloroquine phosphate. Another virus may be parvovirus B19. Transmission usually happens within the first 20 weeks of pregnancy. Symptom gives in newborn, it can be heat drops, also it can be abortions and anemia. For diagnosis, it's PCR of blood, and treatment, suppurative treatment. And Coxsackie B virus, intrauterine transmission, intrauterine exposure, symptoms, carditis or orofacial clefts. And for diagnosis, it's cord serum from specific immunoglobulin N. And for treatment, suppurative treatment care is recommended. So, cytomegalovirus, rubella, toxoplasma are the most common cause of chronic intrauterine infections in newborn. Congenital tuberculosis should be suspected in newborns who have non-resolved pneumonia, persistent fever, in absence of any of bacterial pathogen isolated on culture. DNA PCR to detect HIV should be conducted in a neonate 6 weeks after cessation of breastfeeding. Timely diagnosis of prenatally acquired infection is critical to the initiation of operative therapy, development of care, plan, prognosis, and family counseling.